before we're about to start. You want to make a
Yeah, can you hear me well?
particular yeah.
Can you hear me?
Yeah.
Yeah, okay. I think we'll make a start. Yeah. So, welcome everyone. It's my great pleasure on behalf of the British Kashmiri Medical Association to welcome you all to this COVID webinar. Um, Today's theme and focus is on non invasive ventilation in COVID 19 patients. It's really, a theme is basically about share learning and sharing the best practice between the faculty in Kashmir and UK and United States. As you would have seen the agenda, we have a distinguished panel of speakers, both from Kashmir as well as UK, and we have a distinguished panel of panelists from US, UK, as well as Kashmir. And I know there are a number of faculty members from Kashmir who have joined from across the all the tertiary care and district hospitals. I'm sure it will be an hour of great learning for all of us. Now, before we get going, I think there are obviously some housekeeping measures. Most of you will be muted while we're talking. And if you have any questions, please write in the Q&A section of your, if you go on your Zoom link at the top, or you can also put your questions in the chat box. We will not have any questions answers during when the speakers are talking. We will finish all the presentations first, and then we'll have a discussion at the end. I'm sure all of you will have a chance to speak, and we will have a good interactive discussion. Now, I, as you would have seen the agenda, I'm highly grateful to our speakers from Kashmir, particularly Professor Ajaz Cole and Dr. Zulfikar Ali, who will be joining us from SKIMS. And then we also have Dr. Nick Sherwood from my trust here in United Kingdom, who has been a lead ITU specialist and has a tremendous experience in managing COVID patients. So we had about 4,000 patients in our hospital in over last year. So it'd be great to learn from his experience. Then we also have got, I think, Dr. Neil Richardson, who will be joining from William Harvey Hospital from Kent, who's also an interventionist and ITU specialist. We have Professor Naveez Nazir Shah as a panelist from, as you know him all, he is the head of the COVID unit at CD Hospital. We also have, I think, Dr. Asfar Ali, who will be joining us from North Carolina, who is again a pulmonologist and distinguished internist. We also have Dr. Asim Kichler, who is again a physician from USA and has been at the forefront of managing COVID patients, and it would be great to have him in the panel. And then we also have got Dr. Yasir Rashid, who works here in Oxford and is again an ITU specialist. So I'm sure we'll have a very good discussion at the end. But to start, I just wanted to give you an overview of where we are with COVID in the world. And um, we know that the first case of COVID was identified in China in December 2019, and since then we have moved forward, and a number of milestones have been crossed. Particularly, I think the biggest milestone was the publication from the recovery trial when dexamethasone became the standard of care, and that really saved thousands of lives. And then also important is that we had the first vaccine confirmed within less than a year since the first case was diagnosed. So that's quite incredible. And nowadays we know we are facing these variants all over the world, and that is giving us a headache. Now, if you look at the John Hopkins global COVID map, and millions of people have been infected with this virus, and I've just particularly focused on the India here. You can see about 26 million people infected, about 300,000 lives have been lost to this virus. Just to recap as what happens when we get infected with this virus, as we know, it has got a particular prediction for the ACE2 receptor, which is expressed by both the epithelial and the endothelial cells in the pulmonary epithelium. And um, once it gets internalized, and it leads to a very intense pro-inflammatory cytokine storm in a proportion of patients, which leads to this peculiar phenomenon called microangiopathy or intrapulmonary thrombosis before we manifest or develop an antibody response. And majority of the patients actually do not get unwell; they remain asymptomatic or recover. That's but about 15% of the patients they get unwell, and I think about 5% of the patients actually become critically unwell, and they deal with this typical COVID pneumonia or ARDS, and may need mechanical ventilation. And it's thought that this s- SARS-CoV virus leads to is a highly prothrombotic state, and there is endothelial activation, there is neutrophil activation, which ultimately leads to a cascade of coagulation events, and there is a shutdown of the fibrinolytic pathway, which leads to this peculiar immunothrombosis, also called pulmonary intravascular thrombosis. And if you do a if you do a dual perfusion CT scan
मैं
of this
वेबिनार
patient,
एक इस वक्त अटेंड कर रहा हूँ, ठीक है?
you
मैं
will
एक
see
वेबिनार
that
अटेंड कर रहा हूँ बाद में।
nearly 100%
मैं
of the patients
वेबिनार
who are
अटेंड कर रहा हूँ, बाद
critically
में कॉल
unwell.
करूँगा।
Could you please mute yourself?
मैं बाद में मैं बिजी हूँ।
Please, could you mute yourself? So if you do a dual perfusion CT on critically ill patients, you will see nearly all of them have this evidence of intravascular thrombosis on this scan. Now we also see some peculiar lab abnormalities. This is a paper which we published from our trust recently, and we've shown same what many others have shown, that majority of these patients have a very high neutrophil count and significant lymphocytopenia. So what we have shown is that uh, a neutrophil lymphocyte ratio more than 7.4 or a urea albumin ratio more than 0.28, as well as diabetes and age more than 60 years is associated with high mortality. Now, what's happening in Kashmir and in India at the moment is there are certain unusual features I've been seeing during this second wave. People have seen quite massive numbers, and there's a super spreader phenomenon that multiple members of the same family are getting infected. Younger people and also those who are vaccinated may get infected. And perhaps there is an increased mortality, although it's not been proved as yet. Um, we know that Kashmir has a population of around 15 million, and we're seeing about 4,000 cases daily these days, and on an average, about 50 patients are dying every day. And we know the people are working very hard, and staff are exhausted and fatigued, and the services are stretched. The We're aware that the number of ventilated beds in Kashmir are in scarcity, and it would be very difficult to cope with the number of infections we're seeing these days. Um, there have been a number of sequencing reports, both from Kashmir as well as in United Kingdom, because we have seen the surge of this virus now in UK, as you can see on the graph on the right side, that
شلون الموسيقى لو قلت جوجل ثرو كان
انا سود زوم اسمه
the shown that the variant called B161.7 is now the dominant variant both in India as well as 43 countries in the world. But good news is that the Public Health England has released the data yesterday or this week, which shows that the current vaccines are highly effective against this new variant. So therefore, there should not be any worry. In fact, we should, as healthcare workers, promote vaccination as much as we can. And that is shown by this graph that UK has been at the forefront of vaccination, and you can see the number of the infections and the death rate has dramatically gone down in UK, and we have first time recorded zero COVID deaths in the month of March, which is a remarkable achievement. And if you compare that with India, at the vaccination rate is incredibly low. I think that's a very important thing to keep in mind, that if we want to really get out of this pandemic, we have to promote vaccination. I just wanted just briefly mention that There are only a handful of drugs which have been found to be useful in this condition. And you all know that dexamethasone is one of them. And there's also the monoclonal antibodies like tocilizumab and sarilumab. And recently, budesonide has also been found to be of some effect in patients who are managed at home. And the anticoagulation, again, is recommended, but only in the prophylactic doses. All other drugs which I've listed here on the right side have not been found of any use. Therefore, we should um, you know, be careful that we don't, encourage use of those drugs at all. Just I want to just um, say a word about this condition called vaccine-induced thrombosis and thrombocytopenia, because this is a phenomenon which has been recognized now, um, and probably is the only side effect of the major side effect of the vaccine so far. And it's particularly seen with the AstraZeneca vaccine. And these people often present with unusual thrombosis, and which is also associated with thrombocytopenia. They are characterized by very high D dimer levels and low fibrinogen levels. There haven't been any cases reported so far from Kashmir or India, but as the vaccination drive increases, it is possible we might see these cases. That's why I've just highlighted this. The important thing is that we should not give any heparin to these patients, and they should be managed with either direct oral anticoagulants and intravenous immunoglobulins. Now, the just my concluding slide is that the our immediate focus should be on continuing to vaccine rollout, particularly in Kashmir, because that's the only way of out of this pandemic. There will be some antiviral drugs trialed in UK very soon, while they will be using them in the prophylactic setting in the nursing homes. So we will hear from that. We will also be obviously seeing the phenomenon of long COVID, and we know that can take many forms, but there's a lot to learn about it as what causes it, and is there any way of preventing it. Particularly the issue of long-term pulmonary fibrosis is an issue, and we need to learn about how we can prevent it. And lastly, I just want to introduce this case because this will now become the focus of our discussion today. And I have just picked it from the BMG, and it's a relevant case for as far as Kashmir is concerned, that we have a youngish gentleman who has now been desaturating after getting diagnosed and is not maintaining his oxygen saturation with 4 to 5 liters of oxygen. And how do we manage him? So this will be our focus today. I'm sure the panelists will discuss this and the speakers will discuss this. With that introductory note, I will stop and I will now introduce my colleague, Dr. Imtiaz Said Imtiaz Gilani, who will be now chairing the rest of this meeting. Let me just introduce Imtiaz. I think Imtiaz is very well known, not only in UK, he's also in Kashmir. He is a consultant in the emergency medicine in Kent. He's one of the largest trusts in the Kent. Um, Imtiaz has been a clinical director in the past, is also an IT lead for his trust, and he has a lot of accolades to him in terms of national and local awards. He's a very active socially, and is a very popular person. And I would like to give him a name, but I wouldn't give it. So I will hand over the rest of the proceedings to him, and I'm sure we'll have an enjoyable evening. Thank you very much.
Thank you, Dr. Farooq, for that wonderful introduction. I think you almost called me a social butterfly without saying so. So I don't know if you can hear me okay. Is my voice clear? Yeah. So first of all, assalamu alaikum everyone, and good morning, good afternoon, and good evening to people from all over the globe. I know there are people from all parts of the world in this webinar, right from US, Kashmir, Dubai, and Australia, and so forth. So thank you everyone for joining, especially given the fact that it was such a short notice. In fact, hardly any notice, and I think especially to some of my panel members from US, we hardly gave them a day's notice. So I'm very grateful for that, for the time. As Farooq has very eloquently elaborated the challenge we face with COVID, I don't think I need to add any more to that. I think we all know what we're facing. Other than the clinical onslaught, this disease is an onslaught on other fronts. It's an onslaught on your logistics, on your economy, on society as general. So it has left none of us untouched. And I think other than holding this conference for educational reasons, one of the reasons I wanted this to happen is for a deeply personal reason, which I'm very happy to share with all of you guys. See, some of you might know me and my family, we all had COVID in November. It's me, my wife, my two kids, and my in-laws. And by the grace of Almighty, we scraped unharmed. But we're just counting me and my wife earlier, between the two of us and our families back home in Kashmir, we had 82 COVID cases in total, 82. And of those, luckily, majority had mild illness, but there were 3 fatalities from people who are our distant relations. I also know a few of them needed to be admitted to our hospitals in Kashmir. And these are people who were very sick. So when I say sick, these are people with saturations in low 60s, who were diabetic, had full features of sepsis and septic shock. And were it not for this great skill, compassion shown by my colleagues, friends, teachers who treated them, we might have lost them also. I'm glad to say all 4 ultimately went home. So a huge thank you to everyone. And if I could name a few, I would like to name Professor Ijaz Kaur from SKIMS, and also Prof. Naveed from Chest Disease Hospital, and Dr. Javed Malik, Prof. Javed Malik from SKIMS Medical College, and my friend Sami Mattu from Dubai. There's all people who I was pestering a lot, but they showed great compassion, great skill in helping me at a time when I was in deep distress with my own family and distant relations who had very bad COVID. So there's a very deep personal reason why I want this to happen. So I'm so grateful to everyone who has come today for this webinar, and more so to the greater, august galaxy of speakers we have today. Also, a special thank you to Asim Kichlu, who has joined us literally at he's a panelist. He's from States. He is a pulmonologist there, and also Neil Richardson is my IT colleague here, but he'll be dipping in and out because he has some clinical duties, so he will be joining us briefly. And also a big thank you to Steve Jenner. Steve, are you there? Steve is my critical care outreach nurse. He's an absolute wizard with NIV, so if there's something about NIV he doesn't know, it's not worth knowing, so he'll be part of the panel. So thank you, Steve, for joining in. I know you're doing night shifts and you still managed to wake up at the right time, so a huge thank you. Without any further ado, I'd like to welcome our guest speakers. So I would like to first introduce my dear friend, colleague, a senior from a medical school, somebody I deeply respect, adore, Professor Ijaz Kaur from SKIMS Medical College, SKIMS Hospital, for his first presentation. So welcome, Ijaz. The floor is yours. Thank you.
Thank you very much, Imtiaz. Imtiaz, am I audible?
Yeah.
Assalamu alaikum to everybody, and hello for everybody who has joined this webinar. With the words that everybody in this pandemic has suffered one way or the other, as Imtiaz reminded about his relatives, so many of my relatives had also gone through the same journey, and I lost my uncle and auntie to this disease. Anyhow, we have to go on, and I would like to start straight away.
Ijaz, are you sharing your slides at all, or you
Yeah,
don't?
I'm sharing my slides.
can see your slides, Ijaz. Yeah.
Yeah, sure. Just give me 2 minutes time. I'm sorry for the delay. Okay. I think my slides are visible.
Yeah, go ahead.
Okay. Thank you very much. So I have chosen the topic that coming out of woods. So I don't really know whether we have come out of woods or we are still within the woods. But there is a lot of gloom, there is a lot of apprehension, and there's a lot of insensitivities going on around in my place. So I'm trying to give a mix and match of a hope along with some precautions. If we take a look over the COVID cases, this is the graph of the COVID cases which started in the world right from January 22nd till now. We see a slow rise of cases taking place and the wave one, and then dipping down, and then the wave two. And the other two graphs, on the left side is of the cases in India. It started in the March, it peaked around in September, and then ebbed away, and then had a very sharp spike in March and April, which hopefully we have plateaued and probably we are descending the summit. And in Jammu and Kashmir, we are almost replicating what is the curve in India. Again, we peaked up in the September, and then there was a lull, and we thought everything is over without taking the lessons from the past pandemics. And again, it shot up in the April, and hopefully we are coming out of the woods. In this era of gloom, I want to just share something about the case fatalities. If we see the cumulative case fatalities in the world are around 2.07. These are the top 7 countries as far as the caseload is concerned in the world. In this, the Turkey I find among the 7 with a case fatality of 0.88, and India following it at 1.13. In UK, it has touched 2.86. I cannot contest the numbers here, but we have to at least uh, build our blocks on some data. There may be some underreporting, which I cannot be sure about, but whatever the world data is, we have to construct our blocks on that. And from Indian perspective, if I see that the case fatality in Maharashtra is 1.56 and Delhi overtook it to 1.65. In Jammu and Kashmir, it is 1.32. And I calculated for Jammu and Kashmir, these are the 2 different regions of Jammu and Kashmir for those people who don't belong to J&K. The Jammu is the southern part and Kashmir is the northern part of this hill state of India. And in Jammu, we saw the cases are less than the Kashmir, but in Jammu, the fatality rate was 1.64. And in Kashmir, we were following almost neck to the national 1.12. For overview of the facilities which we have in Kashmir, as Dr. Farooq also mentioned some of them, I think there was a lot of overhaul since the start of pandemic last year. And there were creation of new beds, new facilities. There are around 6 tertiary care hospitals in Kashmir right now, with our SKIMS having a 370 COVID bed capacities, followed by GMC Srinagar, SKIMS Medical College, which we call erstwhile JVC, the Chest Disease Main Hospital, and 2 recently inducted medical colleges. But among them, which I should give a word of praise is for Director Health Services, Srinagar, Kashmir. They could revamp their services to 2,500 beds. And I think it was an impetus for all of us who were working in Kashmir, because mild to moderate cases they used to settle down at this place, which could give us a time to concentrate on the really sick, moderate, severe to critical patients in all these 6 hospitals. I have been associated with the management of COVID right from the March 2020. We tried to compile some of the data, but whatever I could gather from my data, that there are certain groups which need to be addressed properly in my community. Elderly and males, as CKD patients, especially the renal transplants, we had a lot of mortality. Diabetics and obese. There are multiple articles in the literature which are showing now, coming up now, especially in the Lancet last week, that obesity becoming a single important factor for the mortality irrespective of the age. And among investigations, I found that IL-6, if the log of the IL-6 over the period of 8 to 10 days we see is sharply rising, becomes an independent indicator of mortality. And as Dr. Farooq rightly said, NLR. This study we have already published in the Journal of Associated Physicians of India from our Department of Medicine, Sher Kashmir Institute of Medical Sciences, in the issue of May 2021. And what I wanted to highlight is there is a little change in the trend of the age, which I find that some of the younger patients got very sick without so many comorbidities, which I have already mentioned, and some of them lost their life. And the important thing which I want to highlight as a cause of admissions into the tertiary care hospitals of Kashmir is the late arrival to the hospital. There are multiple factors. Although our Kashmiri community is very apt to the medical managements, but there has been certain things which cropped up during this pandemic. People most of the times get treated at home, don't want to come to the hospital because of stigma, because of logistics, because of the COVID and its ramifications. And they try to treat patients at home, although it has been a very boom for all of us physicians because many of the patients are being treated at home care who have an oxygen requirement of 0 to 5 liters. But many of them stretch their stay at homes more, and late arrival leads to mortalities more. Among this, the earlier slides of hope which I showed you, there is an element of helplessness which I have been observing in my clinical practice for these 14, 16 months. I tried in March and April 2020 lopinavir, ritonavir, then hydroxychloroquine, then ivermectin. People used favipiravir, remdesivir. Plasma came with a big boom, and then also went out with a big boom. Monoclonal antibodies, tocilizumab, azithromycin, doxycycline, and now for last 8 to 10 days, molnupiravir is making rounds in the clinical circles of Kashmir. But I don't find any hope among any of these drugs. And why helplessness I am mentioning emerged? Because if we see the world data, $30 billion have been spent on vaccine development in the world. And we have got at least 6, 7 very good vaccines in the market right now, internationally. And around 28 to 30 vaccines are in the process of development. Some are in phase 2 trials, some are in phase 3 trials. But just $10 billion have been spent on treatment development. There are multiple reasons for it, because pharma is not in unison with academia to develop the drugs, probably because of resistance and the lost money in it. So this is a point of helplessness which I wanted to highlight. So our options remain in this pandemic very few. We are watching the house on fire and then we douse the rubble. Have we changed from Spanish flu anything? Paracetamol, oxygen, rest, hydration. This was in Spanish flu. And what, as Dr. Farooq rightly mentioned, the trial which came from the Oxford, the steroids, which made a big change, and anticoagulation for the immunothrombosis in these patients, yes. But until and unless we study the past, we cannot resurrect the future. We cannot create new options. These are the two second waves superimposed over each other of Spanish flu of 1919, which is the blue one, and of COVID-19, which is the orange one. The trajectories are same. the ascent is same, a mild plateau is same, and the descent is same. Only the area under the curve is more, probably because the population is more, 2 billion as compared to now 8 billion. But otherwise, the dynamics of the virus remain the same. So to understand how to mitigate the problem of pandemics, we have to understand the dynamics of the virus. And practically, if we see 1919, this was the first wave, this was the second wave, this was the third wave, which we are anticipating in this also, a small fourth wave, and then the end of the pandemic. But it remained as the undercurrent influenza, which continues till now. So we have to learn from our own mistakes. If we see the RO at that time in the last pandemic also, it ranged from 1.5 to 3.7. Same happened in this pandemic also. From 1 to 4.0 RO. At present, India is at a RO of 0.85. So practically, we are following everything what had happened a century back. As an infectious disease person, this slide is in my office. Is an old slide. And this old slide shows almost all the diseases which are troubling us right from the advent of humanity. Among these, all the viruses or the infections, only the smallpox one is eradicated till date. And the SARS was of 2003. So I have not added still SARS-2 in it. And this whole space is for the viruses which may come in the future. So we have to be very careful in formulating our future policies with respect to infectious disease, which I will be discussing in my future slides. So if we try to learn from the 1919 pandemic, influenza was before 1919 also, and then there was a spike during this time, 1918 and 1919, and the cases drastically came down after some time. This is the normal dynamics of a virus. So it settled down with a case fatality of 1,000 per 100 population down to around 200. And then came the influenza vaccine, and then came the antivirals. And these flames could be doused down to 50 mortality per 100,000. Although then the rise again came, probably because of zanamivir and oseltamivir resistance and other things. But my point of telling is that the influenza vaccine and the antivirals together made life very easy for the clinicians. In the both the situations at present, just 2% of the world population is vaccinated, and we don't have an effective antiviral. So we are not damping and dousing the flames. These are the cumulative data of influenza-like illnesses from 2009 to 2019. And every year, ILI-like illnesses get increased. The green is 2011-12. Then the purple is around 2014-15. The orange is 2015 and 16. The blue is 2016 and 17. And this is the 2017 and 18. If we see that every time ILI-like illnesses are increasing in the world, it has an impact on economy, it has an impact on workload, it has an impact on healthcare system, it has an impact on workman days. I anticipate in next year, this is going to be more sharper than this. Now, in the middle, I had kept a word about the variants. It started from Wuhan, and then we had a variant about UK variant, then South African variant, then Brazilian variant, then 424 American. And then we had a variant in India also, and we never know how many variants we may have. So variants, where should we suspect variants? Where there is transmissibility change, there is morbidity, mortality change, there is susceptibility to the antivirals is getting changes. Ability to infect vaccinated persons are becoming there. You get an immunopathogenesis taking place, and inflammatory syndromes taking place. So all these things cumulatively should activate healthcare system. That are we doing with a new type of a variant? This may happen in future also. This may happen in third wave also. This may happen in fourth wave also. Until and unless we are cognizant of this fact, we are allowing the new variant to go to different places and infect different communities. So variants can be under investigation. That means in a small area where such a change takes place, then it becomes of variant of interest. If many communities experience such a variant, it becomes a variant of concern where WHO comes into being. It involves many continents, many countries, and variant of high consequence, which probably the UK variant already has. And then this is the South African variant, this is the Brazilian variant, this is the Indian variant. And recently, I was studying somewhere that 160% rise in the cases of Indian variant of COVID-19 taking place in UK. That means the virgin population is getting attacked by a variant from different area. So genomics needs a very, very important place in this. I don't want to go into the details of allocating of these types of variants, probably for geneticists, and it is not the podium where I should speak on this, but at least I should tell you that there are few variants which are indigenous to that area, which then spread to whole of the world, like United Kingdom B117. USA has a dominance of 429 and 427, and now probably the California is becoming a hot spot. A new type of a falocate is developing there. South Africa gave ripples there, and about the vaccine.
Judge, we just got 2 minutes left, so I had to give it.
Sure. India and others I have already discussed. Now, our discussions should be little unorthodox. I wanted to highlight few things before winding up. Caregivers respite we are seeing at our place. COVID is a disease where you don't get many of the attendants serving a particular patient. Only the family cares for that patient because of infectivity to others, and it gives caregivers a very tough time. Clinicians have been having a burnout for last 14 to 16 months. We are all part of this. We should focus discussions on post-recovery vasculitis, post-recovery cytokine storm, and post-recovery infections, because we are seeing many patients in Kashmir who, after discharge from tertiary care hospitals, go back home, remain stable for 1 or 2 weeks, oxygen demand starts coming up, D-dimers start rising up, IL-6 starts rising up, and this area is getting neglected. And an important part of our admissions these days is test negative acute lung injury. RT-PCRs are negative, but there is enormous evidence on CTs that this patient might have had or is having COVID negative, is having COVID disease. A red line I have kept, gain of function research. Probably this may be the origin of COVID in Wuhan. There may be a lab breach taking place. Gain of function is very important. There should be a legislation that nobody should be allowed to tamper with the microorganisms, which could be a very, very heinous thing for the future to come. Otherwise, we will get COVID-like situations every now and then. And the future remains with us. For tweaking of vaccines or combination of vaccines, effective antivirals, genomics, and ACE receptor assay densities and the blockers. Probably these 4 things may be a game changers for the COVID in the future. For my place, I should impress upon the authorities that emergency, acute, and critical care settings need to be updated in my place. There should be a revision of medical curriculum with involvement of these 3 as subject in undergraduate medical curriculum: infectious disease, acute and emergency medicine, and critical care. Before thanking you all, I just want to tell you that if we have to get down the flattening of this curve, we need to increase the static healthcare capacity so that this curve becomes this curve. Thank you very much.
Thank you, Dr. Ijaz. It's a fantastic presentation, as always. There are a couple of queries, but I'm going to defer them to the panel discussion just for kind of trying to keep to time. So it's my huge pleasure to welcome now Dr. Zulfikar Ali, who is my schoolmate also, so I've known for many, many years. Zulfikar is an associate professor of neuroanesthesia and ITU, critical care at SKIMS, Srinagar. And I'm very, very keen to hear about the ITU perspective about severe COVID and his experience, because he's thick of it and seen the real kind of the sharp end. So welcome, Zulfikar. Thank you very much.
Thank you, Dr. Imtiaz. Assalamu alaikum, everybody. Good morning, good evening to all my colleagues across the world. I'll be briefly discussing the COVID-19 experience that we have had over the last 1.5 years, as we have been dealing with these patients in Kashmir. As we already saw, Dr. Ajaz, he pointed out, this has been the pattern of disease in our state. And unfortunately, we saw two peaks. The first peak that we came across was in the September last year. And now at this time, we are undergoing the second peak, which started in the first week of May and the last week of April. So what has been the trend of disease in our state? We have had around 20, around 3 lakh patients who were documented with COVID-19 disease. And right now we have 50,000 patients in the state. We have had, unfortunately, around 4,000 documented deaths so far. The medical institutions that have been offering COVID care in the state, primarily Sher-e-Kashmir Institute of Medical Sciences, we have been working very hard day in and day out, catering to COVID and non-COVID areas. This is perhaps one of the institutes in northern India which has been exclusively working in both COVID and non-COVID areas, whereas the other of the institutions, they were either restricted to the COVID areas. But considering the nature of the geographic location and the care that was being offered, the super specialty care in this part of the world, we couldn't afford to close even the non-COVID areas. Then we have other institutes. We have an allied medical college, SKIMS Medical College. They have been doing a wonderful job for last 1.5 years, catering to many sick patients. That has reduced a lot of burden on us. And then our parent medical college, which has been the mother of institutions, but most of us have graduated, the government medical college. They have been running 2 facilities, the Chest Disease Hospital and the government medical college, Srinagar. And again, they have been doing a wonderful job. And in Srinagar district, the Directorate of Health Services, they have been very busy dealing with a lot of patients, particularly with mild and moderate disease at the Jawaharlal Nehru Memorial Hospital. And in addition, we have been aided by 2 medical colleges which have recently started in district Baramulla and district Anantnag. So all these institutions have been combining together, and they have been trying their best to reduce the workload on to cater to the patient population and to improve the outcome. The cases that we see at the SKIMS in the intensive care unit, mostly the cases that do get admitted with us are patients who have moderate disease, severe disease, and the critical disease. So most of the patients that land with us in the intensive care unit, they are mainly presenting with dyspnea. So they land up with the respiratory distress and they have a saturation mainly less than 90 and most of the times less than 94%, and with a very bad CD score once they present to us. Many a times they have a very high FiO2 requirement even once we receive them, because many of the patients, unfortunately, in the second wave. Now, what has happened, most of the patients, they get treated at home, and unfortunately, most of them do not take a proper medical advice. And once they reach to our hospital, they have a very bad disease, a very severe disease with a very high oxygen requirement. We collected some data in the first phase at our hospital, and once at that time the disease was not, it was very poorly understood. And even in the first phase, we saw that we collected, we had one study which we did at SKIMS, and we coordinated with around 26 centers across India. It was way back in February, March 2020. And At that time, we saw a uniform pattern in Kashmir as well as the rest of the India that the markers of severe disease were lymphopenia, increased IL-6 levels, and elevated D-dimer levels. Unfortunately, what we get these days, SCIMS being a referral center, most of the patients that are being referred from other hospitals to our hospital, they come with a very severe disease, and we get a lot of referrals where the patients are in immediate need of pressors. They're already having septic shock. And many of the patients that we receive nowadays, they are either intubated from the periphery or we have to intubate with them within few hours once they reach to the hospital. And some of these patients do present, unfortunately, these days with multi-organ failure. This is the difference that we are having right in the second peak. Once we compare it with the first peak, in first peak, the patients that we were dealing with, there was a decreased incidence of patients who had severe illness. If we analyze the patient spectrum that we deal with mainly these days, we get most of the patients whose age group is around 50 to 70 years, and most of them are males. They do present with dyspnea, and what we have seen is diabetes, hypertension, and chronic renal failure. These are some of the common comorbidities in the patients that are admitted to our intensive care units, along with patients who have malignancies and have undergone various transplants, particularly the renal transplant. Most of these patients, they present with a very low saturation on the room air ranging from around 60 to 90%, and they do have a very severe CT score. What we are doing to most of the patients, they are in need of high flow nasal oxygen. So most of these patients, around 50 to 60% of patients, they are treated with high flow nasal oxygen, while as around rest of the patients, they are managed on non-rebreathing masks. And once we are not able to correct their hypoxia on these modes of oxygenation, we switch mainly to non-invasive ventilation, where we either put them on BiPAP and CPAP. And around 5 to 10% of the patients are still having refractory hypoxia, and there we have to intubate them, and they do get intubated. What we have been observing that the duration of the illness before admission to the hospital or to our intensive care unit, it's slightly prolonged once we compare it with the first week. During the first week, there was a different spectrum that used to come to the hospitals. The hospitals were less crowded, so we had a space to admit mild to moderate patients. But right now, all of our hospitals are overcrowded. And the admissions, once these patients present to our hospitals, it's mainly in the second or the third week after the onset of the illness. Mainly, most of the patients who present to our ICUs, as they present very late, so they are in need of antibiotics. Mainly, we put them on piperacillin, tazobactam, we put them on carbimazepines, and with an adequate staff cover whenever needed. And these antibiotics, they are adjusted as per the clinical scenario. Antivirals we usually use within the first week of presentation, and antifungals we again use as per the clinical decisions. In our patient population, we use dexamethasone and methylprednisolone in low conventional doses, around 6 milligrams dexamethasone, and around 30 milligrams in patients who have moderate disease. But in the intensive care unit, in patients with severe disease on ventilator, we are using high dose steroids for around 3 to 5 days. And then we have been using tocilizumab in few patients, and there is some issue regarding its availability in the market. And once we use tocilizumab, we use it as per the IL-6 levels and the CRP levels based on these two clinical criteria, along with the clinical criteria. And again, we take into consideration, we rule out the secondary bacterial infection along with the procalcitonin levels. And then we start using the tocilizumab. During the first phase of the epidemic, we used convalescent plasma therapy in a greater number of patients. But now, in the second wave, we have not used it as we did not find very good results with the convalescent plasma therapy. We rarely use it. And once we use it, we try to see whether the patient, he has the donor, he has the availability of a high plasma titers of the antibodies. The common complications that we have been encountering in our patient population is that the hypoxemic failure, many a times it becomes refractory. Many of our patients do develop organizing pneumonias or progress to frank ARDS. A number of patients, they do this is the data from very sick patients who are on ventilator. And then a number of patients, they do develop acute kidney injury. And the critically ill patients, we do have a high incidence of multiple organ dysfunction. The challenge that our hospital, our health setup has been facing over the last 1.5 years, and we have been trying to overcome this challenge. This was an unexpected pandemic. It just came in the February to March last year. We have been trying to develop the resource and capacitance building in our hospital. We started before the epidemic, our hospital oxygen capacity was around 750 liters per minute. And now, with the help of our administration, we have increased it around 4 to 5 folds. We have been trying to increase the manpower. We have been trying to increase the supply of oxygen beds. And at the same time, our hospital has been trying to cater to elective patients also, semi-elective patients also, emergency patients also, and COVID care also. I feel very proud of my postgraduates, our paramedical staff, and our all allied staff, in addition to our faculty members, because this is perhaps one of the very few hospitals where at very odd moments only we have stopped elective. Because in this part of the world, the super specialty care, the neurosurgery, the cardiac surgery, plastic surgery, it's offered only at SCIMS. So if we would have closed the elective part of it, it would have caused an equal number of deaths in the non-COVID care as the COVID care. I have just kept a last slide. This is the today's census that we have from SCIMS. I will just briefly summarize this slide. So from this slide, we see that we have had till date around 3,500 patients, 3,428 patients. And we have discharged around 2,597, around 2,600 patients from our hospital. Unfortunately, we have had around 585 deaths. And this is the data we have today. We have around 4 patients today on ventilator. We have around 3 patients on non-invasive ventilation. We have 32 patients on high flow nasal oxygen. And right now we have 71 patients on high flow nasal oxygen. So We have discharged around 32 patients in the last 24 hours, have admitted 23 patients. And unfortunately, we have lost 2 patients over last 24 hours. Thank you. Thanks a lot.
Thank you, Zulfikar. I think I must say I'm a bit numb looking at these figures, and not only shows enormous the task in front of you, and also how hard and stretched you guys have been, because I trained in that place, and it must be pretty intense. There's one thing I wanted to ask you. In the previous presentation also, it looks like people are coming too late and to the detriment. And have we done anything to address that as a kind of a public education or some initiatives to see that people don't leave it too late before they come to secondary care?
We are trying our best. Our physicians, our persons from the Department of General Medicine, Pulmonary Medicine, they are doing their best. What we have done, we have started teleconsultations also at SKIMS. There's a full-blown teleconsultation clinic that is running, and that's operating around 8 to 10 hours every day. So the calls we get in that clinic, we are advising the patients that whenever there are indications of hospitalization, they should report to the hospital immediately. And then again, through various social media platforms, various press platforms, people are doing their work. But the difference that we have right now, once we compare it with the first wave, the patients, any patient who had a COVID-19 disease, there was a strong alarming symptom within the society, and they used to immediately present to the hospital. But right now, in the second wave, somehow the people have got acclimatized to the disease, and many people, they are taking things in a very non-serious pattern. That is unfortunately one thing that we need to address.
Yes, it's tough. I think we had a different problem in this country. We used to have people come too early with very mild cases, which was obviously would put a strain on the services. But it's a big challenge. If people come too late. Thank you, Zulfikar. Obviously, we'll have time in the panel discussion for various queries which have been raised. But excellent presentation. So I'll very quickly move on to my next speaker. That's Dr. Nick Sherwood, who is a consultant in intensive care medicine and anesthetics and clinical lead for emergency planning, preparedness and response at the City Hospital, which is in West Midlands in UK. Thank you, Nick. You've been waiting patiently. I'm really grateful. So the floor is yours. Thank you, Nick.
You should be able to hear me. Is that okay?
Yeah, Nick, that's fine.
Fantastic. Okay, right. So thank you very much for the invite. I notice I'm showing the same picture of a lovely new hospital as Farouk did, because we live currently in something that's very different to that, but it makes quite a nice artist impression.
I copied it from you.
So what I'm briefly going to do is go through what's happened in Samar, West Birmingham over the last year, and then concentrate particularly on CPAP, non-invasive ventilation, and just touch on intensive care management. So just to acclimatise you with where we are, Birmingham, middle of the UK, population of about 1 million people, with about another 1 million in the suburbs around it. This is Birmingham city centre here. Just to acclimatise you, that's City Hospital, which is one of our hospital sites. Sandwell here, that's West Bromwich Albion football ground, that's Aston Villa football ground, but what most of you will know is that is Edgbaston Cricket Club. So that gives you a rough idea of where we are. The important thing is that we serve the northwestern part of Birmingham and the eastern part of what we call the Black Country. The vast majority of our patients come from very low socioeconomic backgrounds, with a lot of poverty and chronic ill health. So it is very interesting listening to the previous two speakers how similar my population is to yours. And again, just to look on the right hand side of the screen, this is City Hospital, which is an 1800s infirmary, and the top one here, that's Sandwell, which is a 1950s creation, but neither of them's ideal. So over the last year, what we've been doing, well, we have on each site 16 intensive care beds. And although we run on 2 different sites, we have a unified team that works between them. So our doctors and nurses move between both sites, rotate between the 2. So we provide the same service on both sites. And we are funded for 18 level 3 beds, or 18 ventilated beds, though we have generic units which have both high dependency and intensive care patients within them. But if they were all ventilated, we could take a maximum of 18. And in peacetime, we normally look after about 1,200 patients per year. We're a little bit unusual in the NHS. In the vast majority of our patients are medical. We don't do an awful lot of planned post-operative surgical care. We've done for the last year virtually nothing but COVID. If you look, this is the April peak, and this is the peak that we had that started in October and has now fortunately nearly completely died off. We've currently got only 1 COVID patient in both of our units. But if you think we're funded for 18 level 3 patients, at the peak, we were looking after 47, 48. Which is a massive ask for the team. And I'm sure you're experiencing similar levels of difficulty and stress on your systems. Sorry, this is a bit crowded, but basically this summarises wave 1 for City, Sandwell, and then the UK average, and then the same for wave 2. Wave 2 for us is anything after September. So just to draw a few quick things. In wave 1, we had about 60 patients on each site. In wave 2, we had far more at City site. If you look at our Black and Asian minority ethnic proportion of patients, City is always high at about 60%, which reflects the population around our hospital. Sandwell, quite low to start with in wave 1 at 22%, but much higher in the second wave. And again, this shows the prevalence in particularly our Asian populations, where there tends to be multi-generational housing. There is occupations put these communities particularly at risk because they don't work from home, they work in shared environments, and there is a higher incidence of hypertension and diabetes. We also have a very, very deprived community around us, with the vast majority of our patients coming from the lowest indicators of social achievement or socioeconomic achievement. In terms of the bottom line, if you look at the UK average for intensive care, about 57% of people survived the second wave. We were running a little bit behind that in terms of City and Sandwell, but this just isn't completely balanced by the standardisation. And we were looking at about a 50% mortality or thereabouts, which is hard for a workforce that's not used to dealing with that level of mortality on a daily basis. Very interesting listening to the previous speakers. My patients are very similar to yours. So in wave 2, the vast majority have had a positive PCR test in the community. They normally present 7 to 10 days after their positive test, and they normally come in with isolated respiratory failure. The vast majority that come to intensive care are 50 to 70. The majority are a little overweight. We have had some patients who are massively obese with BMIs in excess of 50, but they are the minority. Again, the majority are male. The majority of my patients come from my Asian and Black communities, and most of them are hypertensive and diabetic, but I also do recognise the increased prevalence in patients, particularly renal transplants. We've had a few of those as well. So that's what we would know, that's our normal patient. So in terms of ward care, don't worry about the graph too much on the right. What that is there to show is that the thing that we found has worked well for us is standardization of as many things as possible. And the path on the right shows our standardized ward care path for dealing with these COVID patients. So in terms of how we manage them before they come to ITU, we have point of care testing in our emergency departments, and that's vital to make sure that patients end up in the right stream, either a high risk COVID stream or an amber medium risk stream. The next really big take-home message is titrated oxygen therapy. Initially, we were finding every single patient was on a 15-litre non-rebreathe mask, which made it difficult to assess them. And we're now much better at giving titrated therapy to maintain SATs between 92 and 96% and a rest rate below 30. As long as patients stay within those parameters, we will keep them on a ward area. We are very aggressive in pushing awake proning, which I'll talk about shortly. We also start all of these patients on oral dexamethasone. My medical colleagues are still giving remdesivir to patients before they come to ITU, though we stop that when they get to ITU because of lack of evidence in that patient group. And importantly, we've got a very well defined set of ITU triggers where if they require more than 40% oxygen to keep their SATs above 94, that will trigger a referral to intensive care, not ITU admission, but they come onto our a list that we have that we will then keep under close surveillance. Initially, that will be done by our outreach team, which is a team of intensive care nurses who work on our wards, supporting our ward staff. But as the pandemic progressed, the outreach team were pulled back to provide core nurses in ITU. So we then had an ITU support team, which I'll talk about later, who provided the same function. So that's the pathway for our ward patients. As I say, we use a lot of awake proning, and there is a lack of evidence around it, I have to say, but certainly I think we certainly deferred intensive care admission and certainly optimised oxygenation of a lot of patients by using this on the wards. It takes a while to embed. There is certainly an education element for ward staff and for patients, and impressing on them the importance of complying and tolerating with the treatment. And surprisingly, the thing you need a lot of is pillows. We managed to buy several thousand pillows, without which you can't do it. But we've certainly found a lot of patients, particularly younger patients, who were more compliant, where I'm reasonably confident we averted higher levels of intervention by optimizing their oxygenation with a relatively simple intervention such as awake proning. Ward CPAP, we in our hospital, there has not been a lot of ward-based CPAP in most hospitals in the United Kingdom. Most hospitals will have ward-based non-invasive ventilation, usually as a ceiling of care for type 2 respiratory failure, but relatively few hospitals have used CPAP as an intervention, particularly for patients who are for escalation. We basically used our respiratory support unit, which is run by our respiratory physicians and who normally provide NIV, and expanded their capability to be able to provide CPAP and high flow nasal oxygen. However, we did this as for patients where this was their ceiling of care, where they would not be escalated to intensive care. This was largely because of perceived risk of treatment failure and problems escalating that back into ITU, but also we expanded our intensive care to such a size where we could cope with doing the majority of the CPAP within ITU. But we did use this ward area as an ITU step down, and that allowed us to maintain ITU flow. So overall, I'm happy it worked quite well. The things you have to be aware of, as I'm sure you guys know, your case selection is important. And again, if you look over on this side here, we used the 4C mortality score quite heavily in discussions with patients about escalation. It is an aerosol generating procedure, so your staff have to be in full PPE. And the other thing that we found was an issue was environmental ventilation. Whilst our intensive cares are well ventilated, our ward where this these therapies were being undertaken was not, and that caused a problem. We also had to pull our respiratory medical team completely off the medical rota, and we augmented the nursing team by pulling in a variety of nurses from other areas, particularly our outpatient respiratory nurses and our respiratory physiologists, who bulked out the team and did a very good job of decreasing the ITU workload. Again, in terms of standardization, this is our CPAP NIV path. Again, I don't want to dwell too much on it, apart from a few highlights. We don't use A-lines in these patients routinely. Our standard initial CPAP setting is 10 centimeters at 60% oxygen, and then we titrate the therapy down to keep the SATs in the 92 to 96 range. We use moderate amounts of benzodiazepines and morphine to make sure the patient tolerates the therapy, particularly if they're prone. A lot of them complain of discomfort, and some of it's the general myalgia of COVID. And it's important that they tolerate the therapy as much as possible. And the most important thing is regular assessment, particularly for assessment of treatment failure and when you need to intubate a patient. So we use a variety of different mechanisms for CPAP. This is our standard, which is a ResMed CPAP mask, moderately well tolerated. Sizing is critical and difficult to do. We were fortunate that we maintained reasonably good levels of stock of these standard masks. Our go-to, if patients don't tolerate this or if there is significant leak, is the StarMed Castar helmet. Very well tolerated by patients. It is quite noisy because the air inlet is immediately behind your ear, but patients like these, and you can also do non-invasive ventilation through them. A good alternative we found is this Draeger full face mask, which again is well tolerated, and we were for a period of time reusing both of these sorts of masks between patients by cleaning them with Clinell, because we ran short of stock because there was no worldwide stock available. They do tolerate cleaning moderately well. The problems you have is the silicon seal here and here, which will eventually degrade. But although they are single-use items, you can reuse them in extremis. We use these very heavily on ITU. Interesting to hear the comments about high flow nasal oxygen. Because both of our hospitals are reasonably old and our oxygen infrastructure is not amazing, we are limited to how much high flow we can use, because as you know, these will draw up to 50 litres a minute, and our ward areas struggle to cope with that level. We predominantly use high flow nasal for comfort breaks and then for weaning from CPAP. When it works, it's very effective, but it is quite variable, largely dependent on the patient keeping their mouth shut. But we do note a number of risks, the main one being patients really like it, which sounds bizarre as being a risk, but it means we certainly know they get less CPAP with this. It's an uncontrolled amount, probably about 3 centimetres. But it's difficult to persuade them to go back onto CPAP. And we had to do quite a lot of negotiating with some of our patients. Oxygen consumption can be an issue. If you're drawing 50 litres a minute and you're running 10 of these, that's a lot of oxygen in a relatively small area. And the other problem we came across was environmental oxygen contamination. If your patient's breathing out 50 litres a minute of oxygen, that's a lot of oxygen in the environment unless you have adequate ventilation. And there is obviously a fire risk. So we, in our respiratory support unit, were monitoring environmental oxygen levels to make sure they didn't become dangerous. In terms of intensive care, again, we standardise things as much as possible, and I'm sure most hospitals have got flow graphs and flow sheets like this. If any of you are interested in seeing what ours look like, if you contact Farouk, I'll let him have copies of ours, but I'm sure most hospitals have very similar pathways for managing most things. The biggest challenge we had initially was increasing our workforce. If you've got to look after 3 times as many patients, you need 3 times as many nurses. Now, obviously, intensive care trained nurses are a finite resource, and the only way we could expand that was by recruiting what we call reservists, which were nurses working in other areas of the hospital, from a variety of roles, but predominantly from theatres. We did virtually no operating during the 2 peaks that we had. We did our own internal training, but the European Society of Critical Care Medicine has a very good training package, C19 Space. So if you are expanding your nursing or medical workforce and need a training package, that's a good place to look. We found these staff groups needed a lot of support. They are not used to working in intensive care. And when they are on their first shift being faced with 5, 6 patients dying, they require a lot of help. But our reservist workforce were amazing. Medically, we ran we had 2 intensive care units. We then used 2 ward areas for intensive care as well. Every unit was consultant led, and we did that by just massively increasing our hours, and we provided 24/7 on-site cover, bulked out by some of our anaesthetic colleagues who also assisted. The other major thing we did was have an ITU support team, which was predominantly anaesthetists who helped within the unit with roles such as line placement and proning. But also these were the team that supervised patients on the ward to make sure that the referrals we had in were assessed promptly and regularly, so that we were taking people into ITU at the right time. I'm just trying to get my slide to that. So in case you think I work in some swanky nice intensive care, this is what the inside of my ITU looks like. Very small, very cramped, not very well lit. So that's where I work. So the majority of the patients we took were under 70. We never used age as an absolute cutoff, but as you know, there is a very close correlation between age and COVID survival. What we did use was as much data as possible when we were talking to patients to see if they wanted the interventions that we were proposing. And when you spoke to many 80-year-olds who had a number of comorbidities and functionally were not great, about what intubation and ventilation and tracheostomy and weaning and survival post-COVID was like, many of them chose not to have that treatment. We spent quite a lot of time speaking to a lot of patients about that. So about 50% of our patients we managed with CPAP and high flow nasal. Certainly in wave 1, we were following certainly the UK and probably the worldwide approach, which was intubate nearly everybody as soon as possible. And that was associated with a higher mortality than we were comfortable with. By wave 2, we were down to only intubating about 15% of patients in the first 24 hours, and then probably swang back too much the other way and were managing patients on CPAP for too long before intubating them. We're now much better. We critically assess our patients using ROC scoring, and also there are very few patients we will allow to stay on CPAP beyond 72 hours unless they're definitely improving. And I think we're now in a much better place in terms of our timing for intubation. Awake proning I've already spoke about, and we use that fairly rigorously in ITU, and obviously proning patients once they're intubated and ventilated. Just a quick bit about ITU. We go very hard on protective lung ventilation using standard ARDS-NET criteria. We're fortunate to have Draeger ventilators, and our default mode of ventilation is VCSIMV, and we only use a very small number of modes of ventilation in our unit to try and get consistency and to try and do a small number of things well. As a rescue therapy, we use airway pressure release ventilation. We have access to ECMO, not in our hospital or indeed in Birmingham, at Leicester, which is about 35 miles away. But in the whole of the pandemic, we were only able to get 3 patients taken for ECMO because the demand was that high. The standard for our survivors would be a tracheostomy at something between 2 and 4 weeks. And then for many of them, prolonged weaning. And we've had patients staying in excess of 100, 150 days before survival. I think the things I would push are, we've recruited heavily into remap cap and recovery, and being part of research trials has really helped us, because we get a lot of demand from our families for their patients, for their family members, the patients, to be on a variety of drugs that are unproven and possibly dangerous. And we are able to use the fact that we are recruiting into research trials and that these are the only extra additional therapies that we offer. That's been quite useful for us. All of our patients get dexamethasone, but at standard dose. We have sometimes used pulse steroids and higher dose steroids. I think our impression is that the benefit appears to be limited and the harm appears to be not insignificant. Again, there needs to be a good trial looking at this, and recovery is currently looking at dosing and duration of steroids. Diabetes, as you all know, is a major problem with dexamethasone, but we have a very good hospital protocol for managing that. We have access to tocilizumab. We don't have sarilumab. I'm unsure. I was very, very enthusiastic about this. I'm less sure about the place of this now. The evidence is slightly contradictory, and certainly we've seen a number of patients get significant secondary infections. We don't routinely use antivirals. Our antimicrobial policy is very similar to yours. We start off with coamoxiclav usually, and then escalate that to piptaz. Antifungals we'll reserve as second line, but it sounds like our policy is fairly similar to yours. And obviously we have enhanced anticoagulation for all of these patients due to the very high incidence of pulmonary thromboembolic disease. PPE, that's our standard PPE setup, particularly bare below the elbows. Just a very few quick things to finish with. We were fortunate enough to be able to get some extra ventilators, and if you are able to get ventilators, we definitely go for ones that are air turbine driven, because it removes the reliance on medical compressed air to run them. We were using anaesthetic machines early on in wave one and found them very, very ill-suited to use for coronavirus patients with their poor compliance. And the final thing, the biggest thing that I've noted, like you, is the well-being of our staff, who have taken an absolute hammering in the last year. We've done quite a lot of support work and psychological profiling with our staff, and like many UK ITUs, the incidence of post-traumatic stress, suicidal ideation, harmful drug or alcohol use is way in excess of that experienced by combat soldiers, and so that's clearly a big area for the future. So just to conclude, standardizing what you do is really important. In the absence of very many therapies that do very much, the important thing is do the basics really well at the right time. I would again follow the other speakers in saying follow the evidence, and only using evidence-based therapies or therapies within a trial setting. Look after your team, and fortunately you do seem to be coming down from wave 2, but good luck managing the rest of it, and the best wishes of my many colleagues from India and Pakistan are with you. If you need me for anything, that's my email address, or you can get me via Farouk. Thank you very much.
Thank you, Nick. I was absolutely transfixed listening to that presentation. What is quite apparent is the almost same demographic, both in Kashmir and what you see, 50 to 70 people of the same ethnic origin, diabetes, transplant being the main risk factors. A couple of questions which have come through is, are you seeing a lot of fungal superinfections in your severe COVID patients, or not many?
In terms of evidence proven, not that many, certainly way less than 5%, usually Candida species, very little Aspergillus or anything more worrying, possibly because we're fairly rigorous with our steroid protocols and we're only using standard dose 6 milligrams of dex for 10 days. It does seem to be a bigger problem when you're using bigger doses of steroids. Yeah,
I think that's something which we're seeing happening frequently in some of the ITUs in India. So can I also ask you about use of interleukin-6 is quite widespread in Kashmir, and I don't know how much of interleukin-6 does direct your therapy or guides you. Do you use that a lot or not much?
Not at all. That's the one major difference looking at the two previous presentations. We don't use IL-6. We use procalcitonin a fair bit, which in terms of that's usually just for closing down antimicrobial therapy. But in terms of immune modulator markers, we don't routinely measure anything, I have to say, because of the lack of ability to do anything about it mainly.
Okay. So one more question has come through is regarding the mechanism of hypoxia, and when should we stop steroids in COVID survived patients, and what's the experience of recovery after intubation, and when should we start antibiotics in COVID patients? There's quite a few there.
Okay, so starting antibiotics in COVID patients, most of them will routinely end up on usually amoxicillin and clarithromycin, but they're started in ED. We will usually close that down very quickly if their procalcitonin is low. So we'll frequently stop antimicrobials, particularly if they've got CT images which are compatible with COVID with no consolidation and a low procalcitonin score. That then clears us to that we can then start, when patients deteriorate, we've got somewhere to go with our second line, which is pip/taz, or our third line, which is meropenem. But we base that a lot on procalcitonin. In terms of the other questions, which I've forgotten already.
So when should we think about stopping steroids, which we probably anyway, so if you want to elaborate on that.
Yeah, we follow the standard guidelines, which is 6 mg for 10 days, and then we will stop it at 10 days. And then if the only time we have then given a second course is if we've got CT evidence of evolving fibrosis, and then we will go for a pulse of methylpred or a pulse of dexamethasone. I have to say, every time we've done that, it's been completely unsuccessful. Which I think then leads on to the next question about survival and recovery from intubation. I think one of the things that was really difficult for the whole team was in the middle of this, it didn't seem like anybody at all was surviving, because you forget the people that do survive, and all you remember is the many deaths. But we've had a large number of people survive intensive care and ventilation. I've seen a lot of them go out the door, and have felt very sorry for them when I see them go, because they still look awful. But we've just now getting to the point where they are now beginning to come back to see us in intensive care, and they are now back at work well. And even those that have got some respiratory dysfunction are incredibly grateful for what we have done. I haven't come across anybody yet who has not been happy with their quality of life, even those that do have some ongoing pulmonary injury. So it appears to be worth it, is the bottom line. Okay.
Neil is running a bit late, so we still have some time. So one more query about any documented role of sevoflurane in managing the COVID ARDS and associated cytokine storm. It's tough.
Interesting. I ended up using sevoflurane on one patient, but only because they had COVID and an asthma attack, and so we were using it for their asthma. But we haven't used it at all. But we don't have access now to anaesthetic machines, so administering it would not be easy. Not something I've come across, I have to say.
Okay, and one question from me, Nick. I think in good old days when you used to get bacterial consolidations and people who are very sick with severe respiratory failure would always say, look, there's no point in using NIV. These people need intubation because they do so badly. So how come in viral pneumonitis things are so different? What's the evidence for NIV in such patients?
I think one of the major things we have missed in the last year is good quality randomized controlled trials on respiratory therapy. Both oxygen therapy, ward-based therapies, CPAP NIV, and then timing of intubation and modes of intubation is going to be tricky. The evidence simply is lacking. And I think we went into this very much basing our response to COVID on our flu response, which was immediate intubation. And that almost certainly is the wrong thing to do. But I'm still not exactly sure where the balance point is. We certainly shouldn't intubate everybody early. It's worthwhile trying CPAP first. The important thing is not persisting with CPAP when clearly you are not getting benefit. But it's defining what is benefit is the tricky thing. But we're still not there.
That's true. And I think the one point which obviously was important and about risk of fire. I think we've seen some IT in India. There were some fire incidents, and I don't know whether it was the HFNOs were to blame. I don't know, but I think it's something to take home. It's very important not to forget about safety when you have such high flow oxygen devices in use, and especially when there's so many in use. So thank you very much, and Nick. So Neil, our next speaker, is stuck on the internet, so we have some time for questions. So if somebody wants to ask Nick any questions, Zulfi, more than welcome. And Steve, or is Steve still on the line? Steve Jenner. Okay, I think Steve has left. So in that case, so unless anybody wants to ask any,
Sorry, I'm still here.
Oh, Steve, hi. So I'm going to put you in a spot.
You'd muted me.
I do apologize. So
That's all right.
put in a spot here because, if you're happy, do you want to talk about your experiences with regards to using an IV on a day-to-day basis with your patients? Define work or some tips?
Yeah, it was interesting actually listening to Nick's presentation because it's seems like we had a very similar setup side in our trust and at the William Harvey Hospital in Ashford. Outside of the fact, however, that we weren't blessed with quite as many intensive care or level 2 and level 3 beds in intensive care and high dependency. So during definitely the second wave, outside of ITU/HDU in our DG8s, we had for the majority of the second wave on a daily basis, somewhere between 30 to 50 patients on NIV on the wards. And they would be our wards managing the NIV. One was the respiratory ward. So most of the nurses and medical team had some experience with NIV, but actually not specifically with regards to CPAP. That was mainly with regards to BiPAP and home domiciliary NIV. And the other ward actually was our infection control ward, who normally wouldn't be looking after generally patients with infectious respiratory diseases like COVID. So the majority of their, especially nursing staff, had little to no experience with managing acute NIV. So we, in terms of our outreach service, which I'm one of the nursing members, had a horrendous workload. Quite often there would be one, at most two of us on a shift, trying to support the wards with these 30 to 50 patients, managing the non-invasive ventilation settings, mask fits, awake proning, monitoring, blood gases, capillary arterial. So it was a huge amount of work. On top of that, sort of after the first wave, in between the two waves, and throughout the first part of the second wave, we as an outreach team, in particular, two of us in particular, invested a lot of time and effort into education and training of nursing and medical staff outside of ITU, specifically in the two areas that were looking after the majority of these patients, and probably put about 100-ish nursing staff and medical staff through a full day's training and education package in respiratory failure, COVID, and use of non-invasive ventilation, high flow oxygen, etc. So, I mean, we got through it, and it can be done. It is hard work, and you definitely all need to look after each other, is what I would say. I don't know if anybody else has got any questions, or if that's
fantastic. I think, you know, I'm going to take you on that offer because you're doing a session on real-time NIV training.
Yeah.
Colleagues.
Yeah.
Yeah, I mean, I'm happy to support with whatever I can in terms of people need advice or education or whatever.
As I
Hi,
said,
sir.
if
Hi,
there's somebody-
Said. Sorry,
Who's that?
Said. I'm just with Sanjay, actually. It's Pratibha. Can I just have a quick, can I just sort of
Yeah.
add something to what I think Steve just
Can
said?
yes, so can I just, Pratibha, do you want to introduce yourself or do you want me to do that?
Oh, right. Okay. I'm Pratibha. I'm one of the respiratory physicians and director of medical education at the East Kent Hospitals Trust. And I'm the sort of NIV and sleep home and lead for the trust, really. Basically, I think what we're saying is during the first wave, one of the things that we, you know, looking back, obviously what we could have done differently is that we obviously, like what was being said, the respiratory ward is geared up towards actually BiPAP quite a bit, and we've had that service for 20 years now. And we've got one of the largest domiciliary ventilation service outside London, and it's the largest one in the southeast. But what we thought at that point was that the respiratory ward should remain for those who would come in and need non-invasive ventilation who didn't have COVID. So for the non-COVID BiPAP patients, and we converted the infectious diseases ward to the ones COVID patients who needed NIV. And I think that was probably not as good because all the people who were trained in using BiPAP and managing respiratory failure and doing capillary gases were on the ward, which really didn't get many of the home ventilators.
I think you muted yourself.
Yeah. Dr. Pratibha, you muted yourself. Dr. Pratibha, can you unmute yourself? No. Can you unmute yourself? Sorry.
Sorry, I think it sort of went
No,
somewhere like that. So I'm not,
no.
I think I don't know where it got cut off, but basically to sort of say that during the first wave, we turned the respiratory ward into a non-COVID home BiPAP and other BiPAP for patients with who are on BiPAP for other reasons, and identified the infectious diseases ward as the COVID BiPAP ward. But what we realized is that out of the 750 home ventilated patients, hardly 1% actually got admitted. So we had the trained people on a ward where we didn't have many BiPAP patients at all. So what we then did was, in time for the second wave, changed it. So we flipped the wards actually. So we changed wards and we got all the people who were trained to the main respiratory ward to become the BiPAP COVID ward, and the infectious diseases ward almost became a subsidiary. And certainly our critical care outreach team were really happy with the second wave, I think, and the way it went, because, and so were our respiratory nursing team, because they were doing what they were trained to do. And whilst everyone was asking how the morale was and everything, they felt that they were able to actually do a lot of the work they did. So I think lots of lessons, and that second wave, as was saying, was about 3 times the number of patients on non-invasive ventilation as the first time. But we actually had a third ward as well, which normally would have been a general medical ward, which actually we had to convert and make sure that resources were available to do it. And oxygen as well. That was another different story altogether, which we keep seeing all over the world. And I can easily understand the pain actually of trying to make sure that you don't run out of oxygen, which was such an alien concept 18 months ago. And in Italy, they were talking about running out of oxygen, and somebody came on TV and said, I remember that from Lombardy, one of the doctors said, make sure you don't run out of oxygen. I was thinking, what on earth is he talking about? And then we very quickly realized what they were talking about, I think. And so I think it's been lots of different lessons learned, but I think we hope that the third wave is definitely not as big as the second.
We all pray for that, Dr. But thank you for that update. So
Imtiaz,
running
can I,
very short of time.
Imtiaz, can I make a
Yeah.
can I make a comment? Sorry.
Yeah.
I just wanted thank you all for your excellent presentations. I just wanted Dr. Zulfikar Ali and Nick and the other panel members to talk about. I mean, it looks like that the number of ventilated patients in Kashmir is obviously low. Um, we know that the mortality of patients who go on ventilator, if you see the UK experience, as Nick has shown, is quite high. It's about nearly 40% people die. Is that a reason that we are not ventilating patients in Kashmir, or is that because they don't need it, or is that because of the support issues there? And I just wanted if Nick and Dr. Ali can interact on that, please.
It's a very, very interesting question for it, which I do not have an answer to, I'm afraid. There is something about what happened with COVID in the UK with our very high case fatality rate that will eventually be unpicked. But I don't think we really understand how it got so rampant so quickly. And it may be something to do with that. But certainly our 50% mortality, the bulk of that was in patients who were ventilated, but the ventilated patients self-select. If you go through CPAP and fail CPAP, you will be intubated and ventilated. And so we had very, very, very few people die whilst on CPAP. But yeah, overall, we ventilated about 40-45% of our total ITU admissions. So a much higher proportion.
Thank you, Nick. I think we're just running behind time big time, so I would like to move on to our panel discussion. And so I think we can talk about some of the things which were raised earlier on. So I don't know if Asfar are you there? And Yasin has left because he Prof. Navi, are you still there? I know it's getting a bit late in Kashmir.
Yeah. Assalamualaikum.
Okay, sir. Assalamualaikum. Thank you, Navi. Any thoughts so far? So what you had so far, does it chime with what you see in your unit?
Yeah, what we have observed in our ICU and respiratory wards, we find that we have best results with the non-invasive ventilator and high flow nasal cannulas. We have managed to get a lot of people out of their respiratory failure using these two methods. Regarding ventilation, I think everybody is on net these days, and they see the outcome of the ventilation is quite poor, what we have seen till now. So majority of the patients who are offered ventilations shy away from it, don't want to get ventilated, and probably agree to it at a very late stage. And we have seen that most of the patients who go on ventilator in our part of the world don't come out. So what we have seen is we get better results with while using NIVs and high flow nasal oxygen.
Asfar, do you want to? Asfar, are you still there? No.
Yeah, hey, I'm there.
Asfar, do you want to? Any thoughts on that? What was your kind of experience with intubation in the patient, and what's kind of a pattern you saw in your practice?
Yeah, I think the key to this is that, the initial scare we had in New York last year when, there was a very high mortality with intubation, and everybody kind of got scared and tried to push these patients beyond their limits. And late intubation, I think we have come a long way from that. And, the key to using, obviously Kashmir is different based on resources available. They don't have respiratory therapists, which is a big issue. These, COVID, we need to make sure that we don't treat this patient population as a homogeneous group. It's everybody who has COVID as is on like 8 liters or 10 liters does not mean that they're doomed. So within the constraints of the resources for that particular hospital, we do need to kind of work with that. Our experience has been that, we do use non-invasive ventilation, but it's mainly to kind of with close monitoring to tide over some patients who are, who they are meeting the criteria as were discussed already. And but we have a low threshold for intubating and putting them on the non-invasive if they fail. The key things we monitor is obviously the carbon dioxide level, their mental status, and their improvement, because what you're trying to get is more recruitment with the CPAP, is the positive pressure. And I think that may be the key in Kashmir too, is there's a lot of resource issues with resources there because we don't have respiratory therapists, and that may be an issue in kind of using non-invasive, because in my mind it needs a lot of kind of monitoring to see that patients are not failing, and a low threshold for intubation as well. But we have had good luck with patients here who transitioned in the short run, and given time for the steroids to work, or for them, as long as they're awake, alert, able to not get tired, their CO2 is not increasing, and we can maintain some degree of hydration and nutrition with close monitoring. I think that's the key for Kashmir too, is some of these patients that we heard do need monitoring, and that may not be always available there.
Thank you. As for Yasser, can I ask you the same question? In fact, a different question. So the feedback I get from colleagues in Kashmir is people find it really hard to tolerate CPAP or NIV. Do you think it's a kind of question of not right patient selection, or do you think something else is at play? How can we address that? The feedback is become very tachycardic, they're not able to synchronize and so forth. So if you want to share your experiences regarding.
Well, thank you very much for the question. But what I've just observed from the data that's been presented by Dr. Ali from SCIMS, they have at the moment 71 patients on high flow nasal oxygen and 103 patients on high flow oxygen, and then medium flow oxygen 136 patients, and only 4 ventilated patients. So it doesn't make sense that patients are not tolerating CPAP. They have got majority of patients on high flow oxygen therapies. So, and I wanted to ask Dr. Zulfikar that do they have escalation therapies between different modes of respiratory support? For example, if somebody is on medium flow oxygen, what happens then? What's the escalation therapy for high flow or high flow nasal oxygen? And what works out in terms of numbers, if we're looking at 5,700 liters per minute oxygen supply for the hospital, and having about 170 patients on high flow oxygen, it's quite, complicated to me to understand how that's working. But in my understanding, patient discussions are important, patient selection is important. We also have to take into account for all these high flow oxygen therapies, what's the backup? What's the backup plan for them? Because a good majority will fail that therapy. Do we have intubation facilities? Have we got those escalation plans? That was my question, which I was planning to ask anyway to the team in SCIMS.
Yeah, Dr. Yasser, basically right now we have around 30 high flow nasal devices that are operating.
Yeah.
So at a particular point of time, we have around 27 high flow nasal devices. And the COVID care patients that are being taken care, they are not at a single place. We have an IDB block where we have around 28 to 30 patients. And there we have concentrated facilities for high flow nasal oxygen. Then we have converted our surgical observation. Again, we have converted into a COVID ward. And there we have again patients on high flow nasal oxygen as well as ventilators. Then we're trying to start one ward 2A, as we call it. So there we have put patients on again ventilators and high flow nasal oxygen. So there are different manifolds running in different areas of the hospital, and that's how we are catering. Definitely there are problems with the flow of oxygen. It's not like that we have a regular oxygen supply at all times, but
I
we
can
are
fully
trying to.
understand and what you are facing
Yeah,
in terms
yeah.
of
The
supply.
second thing regarding escalation of oxygen therapy, we are following protocols. What we do initially, most of the patients with moderate disease, they are initially put on non-rebreathing mask. So if we are not able to maintain their saturation, their disease progresses. So then we either put them on high flow nasal oxygen or this BiPAP or CPAP, depending on the availability of resources, because it's not that we can follow a rigid protocol that we have a failure with a non-rebreathing mask and we'll switch over to high flow nasal oxygen. A device has to be available.
Okay.
Considering the number of stress that we have on our resources right now is immense.
I mean, just
we can sorry.
So
can I just come in? Sorry, yeah. So I think just for the sake of time, I think, as I said in my introductions, the onslaught on your whole healthcare economy is not just about clinical criteria. It does stretch you on all levels. So absolutely get that. I've got a couple of questions. That's why I had to interrupt. So for the panel, COVID hypoxic patients have poor tolerance for proning, which becomes more difficult with NIV CPAP. Please suggest optimization and any use of sedation to increase patient tolerance, especially when there's about to be proned, especially with all this hardware attached to their faces. Any tips or from the panel or Steve?
I think, can I say?
Yeah, sure. Yeah.
I think that's been already debated in the chat room first, but I think there were a couple of things. I think Nick mentioned that we should have very careful observation and monitoring for those patients who would be sedated, but that will be ideal in ICU settings. Apart from ICU settings, we need to be very careful if we are trying to sedate a patient who is going into acute respiratory failure. And that too, then we are on some non-invasive device. So it has to be, again, it's a very difficult challenge for our colleagues, because in terms of the available monitoring and resources, what I was thinking, like if we're looking at the arterial blood gases, I don't know how much they are easily available and how many kits they have got there all the time. But thinking about ROX index might be an interesting thing to, use as an escalation in their escalation protocol. Something like that would help to switch from conventional oxygen therapy to devices like HFNO, high flow nasal oxygen, or CPAP or NIV if needed. Yeah.
Yasir, as far as the lab facilities are concerned, we are not having any major problems. We are very comfortable with arterial blood gases and other biomedical markers. That's not the issue. The main issue right now is the availability of the devices, particularly the high flow nasal oxygen devices. There is some issue regarding that, which we are trying to address.
Yeah.
So, Steve, I think in our trust we did have a kind of we blacklisted HFNOs, didn't we, Steve? Because of the pressure on oxygen supplies. Steve, are we still using them, or obviously there are not many patients who need that now?
Yeah, so two things. Just going back to the issues around compliance and tolerance in terms of CPAP and awake proning and things. It is difficult, because actually using mild sedatives or drugs of similar ilk in our standard respiratory patients, we all kind of frown upon, and it's a bit of a safety issue. However, through experience, these COVID respiratory failure patients tend to behave very differently to our standard generic respiratory failure patients. And actually, what I found is a lot of the issue for them in terms of compliance and tolerance tends to be anxiety rather than anything else. And so we did from time to time in selected patients use occasionally some low dose diazepam or drugs of that like, just to help try and ease anxiety levels. Obviously not on a routine, regular basis, but at times when we were needing to try and get them to awake prone and things like that, or those particular issues with compliance, we would consider and sometimes use low dose diazepam or other similar drugs. So that's something to consider, although it does go outside of our normal thinking with respiratory patients on non-invasive ventilation. In terms of high flow nasal oxygen, like I said with our trust, initially, definitely during phase 1, we weren't using high flow nasal oxygen for 2 reasons. A, most patients were getting intubated very early doors. And secondly, we, in terms of infection control, felt that using CPAP with a full face mask seemed in theory to be less aerosol generating than using high flow nasal oxygen, where a lot of the air is breathed back out into the environment. With CPAP with a full face mask, a lot of the aerosol is contained within the mask and rebreathed by the patient. That said, and also because of the concerns about oxygen consumption with the high flow nasal oxygen devices, and at that time within our site, there were pressures about the amount of oxygen supply that we'd got. That has now been addressed on our site at Ashford, and we've had new oxygen compression cylinders fitted, and actually the concerns in terms of aerosol generation, the guidelines are, I think, actually in terms of aerosol generation, high flow nasal oxygen is not any more of a concern than using CPAP with a standard mask. So in the second wave and ongoing now, we are using high flow nasal oxygen devices again, even with COVID patients, definitely for periods of meal breaks, comfort breaks, weaning, but also sometimes in COVID patients that can't tolerate CPAP, we will consider high flow nasal oxygen if we've got them in an environment where they're in an isolation room and the ventilation is appropriate.
Thank you, Steve. We just got 4 more minutes. I would just like to ask the panel members to one take-home message regarding NIV in COVID patients, or anything else they want to, as a take-home message. So, Prof. Naveed, so is it from your experience with COVID at the front end, what would you kind of ask us to take home as a take-home message? Prof. Naveed? Okay, so move on to Yasser.
I think from my point of view, discussing the patient, the treatment plans with the patient before putting them on escalation therapies would be most important. And looking after yourself as staff and between the medical staff, nursing staff, having good inter-team relationships will be really helpful. Looking after each other's emotional health will be quite important through this pandemic.
That's a great point, actually. Yeah. As for any take-home tips, points for the audience and us here and everyone else?
Yeah, I know the team in Kashmir is doing a great job, but what I would like to, kind of say is we have to find that sweet spot of where to intervene. I find that on talking to people there, talking to patients, sometimes I get a feeling that they're pushed too far before intervention, either with CPAP or intubation. They are like 60% or whatever saturation for like days before these, if there's a sweet spot. I know we can't do it too early because of resource issues, but sometimes it's just a mute point at the point where intervention goes. And also, so if we can have like a protocol that is adapted to Kashmir, then I think that would be ideal. I know we cannot dictate in the hard conditions that they're working in. So, but they have to come up with, their own protocol where, there's not the delay, because what we have seen is if you delay that treatment and by the time the patient is tired, breathing on like 30 times, 40 times a minute, they at that time it's too late. You can't use CPAP. They're hypercapnic already, and they don't have the monitoring of CO2 and all. That's like at that point, that's written, already we're gone too far. And the other thing, I think that's the point, maybe not related to this. First, I think that there's one issue that I heard that a lot of high dose steroids being used, which is, I know the discussion has been around mucormycosis and all. I see that, with the dose we use is the maximum for like 32 milligrams of Medrol, which is like equivalent to that 6 or 8 of Decadron. And I heard that some, places are using like 250 Q6, which is, I think it's actually shown to be, increase in mortality for some of those patients. Those are the 2 points that I had. Thanks.
Thank you. So I think we'll take this next time for the pharmacotherapy, because I seen a 1 gram MPS prescription today, which was a bit worrying, but that's for another time. Thank you, for that. Yeah. Yes,
Can I just add a last point? While we're doing all these escalation therapies, this is particularly for ICU group of doctors who are here. We have to emphasize on the sterility of instruments and the humidification equipment, especially, and using sterile water for humidification. There is a high risk of transmission of infection through those devices.
Thank you, Yasser. And it's getting very late in Kashmir, so thank you, guys. I'll just request now Dr. Farooq to do his closing remarks. And ideally, I think if anybody else from our guest from Kashmir wants to have one final word, that's be just before Farooq closes the session. Anybody else want to? Okay, thank you. So, Dr. Farooq, do you want to make your closing remarks?
Yes, Saeed, I want to talk. I'm Dr. Talib. I just want to talk regarding the management of these patients. Definitely, the management is going to have an impact on the patient outcome if we do the early intervention. Azfar is right in that. So the patients which land up in schemes are already exhausted, and they are referred from the different centers of the Kashmir Valley, because our center is the tertiary care center receiving the critical patients from different parts of the Kashmir. From different catering hospitals who are dealing with the COVID. Number one. Number two is that we are seeing the patients definitely who are receiving the very high dose of steroids, which is not good. These patients, some patients, I have come across few prescriptions where they have even used the 1 gram of the steroid. Unfortunate. The basic studies which have been done was on the 6 milligram of the dexamethasone for 5-10 days. That was the game changer. That has come results with the literature in randomized control trial. That should be used. We should use the load, because steroids have an immunosuppressant effect. They can mucormycosis, fungal infections, and so many things can happen. Antibiotics should be judiciously used. And one thing I want to tell, that once we discharge the patient of the COVID, we should go ahead with the post-COVID vaccination, like the pneumococcal vaccination, Haemophilus vaccination, and the flu shots as well, besides the COVID vaccine. That's very important. We should not let the patients to have the pneumococcal or streptococcal infections. We should take care of that as well. And pulmonary rehabilitation therapy, and we should give the people, the public, the community a word, so that they should be trained about the pulmonary rehabilitation, not only once they are admitted, proning at hospital. No, they should get started preemptively. These things, they should be trained, because we don't know who will get the COVID, who will not get the COVID.
Thank you,
Very important.
That's a great point, Talib.
Thank you.
Very late in Kashmir, it's 11 p.m. already, so very quickly, so Dr. Farooq, you want to make your closing remarks, and then we'll conclude the session.
Yeah, thank you, Imtiaz, for sharing this session so nicely. I must thank all the speakers and the panelists who participated today. And thank you all for joining. And I'm sure this was a very, very good learning experience. And what I could probably take away from this is that, I must congratulate the doctors and healthcare workers in Kashmir. I know we understand they're working under very difficult circumstances, but we're not alone in this pandemic. We're all a global community, and we're all fighting it together. Um, what I could take away from this is one of the things that we must have standardized pathways. I think that's what I could look at. Uh, one of the panelists did say that patients do present very late, and perhaps in the periphery, we may not have as standardized a pathway as in the central places. So I think that if that could be worked at, how you get the patients referred to the tertiary care. I think, as Nick said earlier on, that we must get the basics right and practice evidence-based medicine. Let's not look at the anecdotes, and let's see what's published and just stick to that. And obviously, these are very difficult circumstances. The staff is stretched, the services are stretched. I think there's a time that we must support each other, and also take care of the families, the relatives of the patients, because often you can see that doctor is probably the only point of contact for them because they are not allowed to come to the hospital. So it's a time for compassion and in fact more compassion. And I think the other point I want to make it is it doesn't it look that although non-invasive ventilation is the kind of initial mode of treatment for these people, but uh, there is a room for ventilation, and I think you must use the criteria for choosing those patients, as the experts have already said that. And lastly, I want to emphasize that as healthcare workers, particularly in Kashmir, I think we must promote vaccination. Vaccination is the only thing which will take us out of this pandemic. And the good news is that vaccines are working against the previous variant as well as the new variant. So I think that is the thing which we must promote, and hopefully we should get out of this pandemic. I want to thank you again, the members of the BKMA, the faculty from Kashmir, and all the speakers from UK, US, and wherever you joined from. Thank you very much. We hope that we will perhaps have a few of similar seminars in the near future. I wish you all the best. I think we come to an end of this meeting. Thank you very much.
Same from here.
One last thing. So very quickly, Steve Jenner has very kindly agreed to do a real-time NIV training session. I'm telling you from my experience, he's the man to go to if you are struggling with NIV. So he knows it inside out. So I already spoken to colleagues from JLNM with Nasser and Arif Said. So if anybody from the audience wants to be part of that, anybody with interest in NIV, please do let me know. I'm going to arrange a session soon. I'll be both theory, and we'll try and do it as much real time as possible. So let's keep that in mind. And thank you very much for listening.
And just a last point, sorry, the recording of this will be available on our website, www.bkma.net, and we'll also put on the YouTube for those people who may not have been able to attend. Thank you very much.
Thank you. This meeting is concluded. Thank you.
Thank you. Thank you, everyone.
Thank you, everyone.
Everybody. Salam alaikum.
Janab.
Okay.